Good afternoon, everyone, and thank you for joining us for today's webinar entitled, Dude, Where's My Liver? Is Cannabis a Barrier to Liver Transplantation? We're glad you could all join us as we have an exciting presentation in store for you today. My name is Deanna Fenton, and I am the Program Coordinator with the Alliance. We just have a few logistical items to review before beginning today's program. For those of you who have never joined us on this webinar platform before, if you have any questions during the course of the webinar, please feel free to utilize the chat feature, which is located in the bottom left-hand corner. Please feel free to submit your questions at any time. Once the presentation has concluded, we'll ask our presenter to address as many questions as time allows. We are recording this webinar, so we will not be opening the phone lines. That means that all questions must be submitted electronically using this chat feature. Registration is currently opening for our upcoming innovation webinar entitled From Conception to Birth, the Evolution of Uterine Transplantation. So please join us for that on July 19th at 2 p.m. Eastern. Registration is also open for our next webinar entitled Palliative Providers, Perfect Partners. That's coming your way on August 14th at 2 p.m. Eastern. You can register for all these webinars and more on our website at organdonationalliance.org. For today's webinar, we are offering 1 CEP-C credit and 1 nursing hour credit courtesy of Iowa Donor Network. Everyone listening to today's webinar is entitled to claim continuing education credits. If you are listening in a group, as many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which allows you to receive your credit. As a reminder, for nursing, you have 14 days to claim your continuing education credits, and for CEP-C, you have 30 calendar days. At this point, I would like to introduce our moderator, Andrea Tejan, Director of Transplant Finance, Data, and Quality for Renal and Pancreas Transplants at St. Barnabas Medical Center. She is also a member of our 2018 Webinar Faculty Committee. Andrea, we are so glad to have you with us today, and at this point, I'll turn it over to you to introduce our speakers.
Thank you, Deanna. Good afternoon, everyone. It is my pleasure to introduce today's speaker, Dr. Winder. Dr. Winder is a clinical assistant professor of psychiatry at the University of Michigan. He holds a medical degree from the University of Utah School of Medicine and a Master's of Science degree in research methods from the University of Michigan School of Public Health. He also completed his general psychiatry residency, followed by a fellowship in consultation liaison psychiatry at the University of Michigan. As a consultation liaison psychiatrist, Dr. Winder specializes in the psychiatric care of the medically ill and has co-founded mental health clinics in organ transplantation, neurology, and hepatology, where he works on multidisciplinary teams which provides integrated psychiatric and medical care to patients whose diseases transcend a single medical discipline. His academic interests and passion are in both addiction and liver disease, and will be sharing his expertise with us on today's topic. Please join me in welcoming Dr. Winder.
Hello, everyone. Thank you very much, Andrea, and thank you to the Alliance for having me. This is a very important topic, and one that, as a profession, we will be learning much more about in the years to come. I structured my remarks today to try and reach as many of you as I can. It's certainly an honor to speak to as many of you as I am from different parts of our field. My intent is to raise perhaps as many questions as I answer. There's little that is known because of how much is changing in our society and our laws related to marijuana, and also in our minds as we, more of us use marijuana and more of us consider its presence in our society. My objectives to do that, to accomplish that, if I'm fortunate enough to accomplish that, would be to divide my remarks in the following way, and hopefully by the end, ending with some ethical questions that I wouldn't presume to answer, but wanted to leave you with several questions that I've spent some time in my clinical work thinking about and wanted to leave with you. They're only some of many, but we'll get started. The more I work with transplant patients as a psychiatrist and mental health professional, as somebody who thinks a lot about human nature, I love this quote. And much of what we encounter with marijuana gets right to some of the core parts of human beings, even past our physiology. And we really do transplant human beings, not angels. And part of human nature that we see through addiction and substance use and marijuana is some of the grittier parts of who we are as people, which makes it so interesting and worthwhile to spend time thinking about it. I spent some time talking to multidisciplinary audiences, and this is a quote from a neurologist who I certainly respect and admire, and I'd share it here as well. The distinction between diseases of brain and mind, between neurological, and I would add medical to that, problems and psychological or psychiatric ones, is an unfortunate cultural inheritance that permeates society and medicine. It reflects a basic ignorance of the relation between brain and mind. A lot of the themes that I will talk to you about certainly center on brain and mind, and I wanted to upfront tie that into people, human nature, but also medical and neurological science. Throughout human history, marijuana has had a role and a place in human society. Marijuana, as we know it, is primarily two species, Cannabis sativa and indica, indigenous to Central and South Asia. And various uses have been identified over millennia, both for physical objects, for farming, for religious practices and medical care, and certainly for recreation. More focally, and more recently, in the United States, marijuana was first criminalized by the Marijuana Tax Act of 1937, which was the government essentially responding to societal and public outcry about the prevalence and ills of marijuana perceived at the time. During the Nixon era, the Controlled Substances Act of 1970 was passed, and this is where marijuana obtained its Schedule I status. The verbiage from that designation is that it has no currently accepted medical use and a high potential for abuse. And this is an abbreviated history, certainly, but some of the high points. California in 1996 was the first state to legalize medical marijuana, and now more than half of our states have medical marijuana as something that can be legally accessed, and we'll talk more about that in a bit. A little bit of epidemiology to further set the table. Marijuana is the most common illicit drug in the United States, and of course that's in quotes because of the evolution in its legal status. About 12% of people in the United States above the age of 12 have used marijuana in the past year. In 2015, more than 11 million young adults from the ages of 18 to 25 had used marijuana in the past 12 months. There's increasing perception on the part of young people that marijuana is safe, even in regular use. And nowadays we can count on a general population rate of problematic use, a marijuana or cannabis use disorder, at about 3%. This is some data for U.S. students, U.S. seniors, between 1975 and 2013. Let's see if I can give you a pointer here. The blue here is the students who had used marijuana within the past year. And the red indicates their perceived risk, which is defined as the percentage of teens who reported simply that marijuana is dangerous. And you'll appreciate here an inverse relationship over the years. And we're certainly, if we fast forward here, seeing that the perceived risk is decreasing and use is increasing, and we can count on that continuing. To hold that up against another widely used substance, down here we see cigarette use in the past 30 days and marijuana use in the past 30 days. And we see some downward trends with nicotine and certainly some stable and increasing trends in terms of marijuana. I wanted to outline some basic pharmacology because it has found its way into our vernacular. The main psychoactive ingredient in marijuana is tetrahydrocannabinol, which is active at the 2 cannabinoid receptors that interestingly were discovered by THC before we actually understood what endogenous cannabinoids, or cannabinoids that our body makes, what they were and what they did. The CB1 receptor is primarily in the central nervous system, and the CB2 receptor occupies several sites in our immune system. Inhaling THC produces a rapid serum peak in our blood, and it has a short half-life. It's rapidly cleared and metabolized, but the metabolite that forms is quite persistent, as we know when we use toxicology. And the substance itself, THC, is lipophilic. Because of these carbon rings, it deposits easily into adipose tissue, and for this reason, we know that we can pick up marijuana for quite some time, especially in chronic users. Its effect on the brain increases dopamine, which is very similar to other addictive substances that the human family uses. The mechanism by which it does it is certainly unique, but we shouldn't make any mistake that it stimulates pleasure in very similar ways to other substances we often encounter and think about. The endocannabinoids that our body makes naturally are anandamide and 2-AG, and they have various functions throughout our bodies in terms of metabolism, inflammation, regulation of bone mass, and anti-tumor action. They're vasoregulators, and they also have a role in the formation of lipids. Pharmaceuticals are on the market that include Marinol and Nabilone, some of which some of us have likely interacted with these on the medical floors or in the clinics. They are indicated as antiemetics and appetite stimulants and analgesics. And they are Schedule 3, which is important to think about when we think about marijuana itself as Schedule 1. I wanted you to see the verbiage from the Schedule 3 designation that these substances have moderate to low physical dependence or high psychological dependence properties. Outside of our country, our Canadian and British colleagues have access to a formulation called Sativex, which is a 1-to-1 formulation of THC and cannabidiol, which is approved for spasticity related to multiple sclerosis. It's interesting to note that the action of marijuana that we're familiar with in terms of appetite stimulation was explored pharmaceutically, and rimonabant, which is an inverse agonist at the CB1 receptor, was investigated and was briefly available, but because of severe side effects, psychiatrically, it was withdrawn from markets outside of the United States in 2008. We often hear our patients talk about CBD. What they're referring to, as many of us know, is cannabidiol, which is a unique and interesting cannabinoid that has lower activity at the CB1 and CB2 receptors and has various other interesting and as yet to be explored therapeutically receptor activity, which includes serotonin and glycine neurotransmitter systems. Interestingly, its natural occurrence in cannabis sativa and cannabis indica is thought to mitigate or treat, offset the THC-related side effects that we'll chat about in a little bit. And many of us know about synthetic cannabinoids or designer drugs. K2 or spice are ways that these are referred to in the popular media or in our communities. They're very dangerous drugs. One of the reasons they're so dangerous is they lack a mitigating factor like cannabidiol. They simply stimulate the receptor without any offset or any mitigating factors. And they have a much higher propensity to stimulate the receptor than natural THC. Cannabidiol has a low abuse potential. It's not thought to be something that would be addictive widely. And its anti-epileptic properties and anti-inflammatory properties and its neuroprotective effects are highly attractive as potential therapeutic, as a therapeutic agent. And we're building a portfolio of high-quality clinical trial data, but this is ongoing. Legalization is an important part of this, and I wanted to give, not being an attorney or an expert in the law, I did want to do my best to give you some useful information about legalization. I'm talking to a broad audience, as I understand, over various parts of our country, so I can't touch on everything, but wanted to give as much as I could. This is an updated, to my knowledge, map, and I'll kind of leave it here for everybody to peruse. The darker the green, I guess we could think, the more legal the substance is. And a lot of this will resonate with you if you watch the news or if you live in one of these places. There are parts where medical and recreational marijuana are completely prohibited, but things are changing. I hail from Salt Lake City, and that's not a place where marijuana is very popular at all, but you can certainly see that even Salt Lake City is undergoing a change in their mindset towards medical marijuana. The red Ds that you see are decriminalization, the idea that even though it's not fully legalized for recreational use, that possession or use of marijuana would not trigger a criminal proceeding, but instead would be more of a civil infraction. This is a crowded slide, and I apologize. What I wanted to give you, maybe more for the handout than during the presentation, I just wanted you to see some of the verbiage that is used in the legislation, because I think it's informative to think about this issue, particularly maybe in the California Act here at the top. Verbiage like this, or any illness for which marijuana provides relief, makes some critics of marijuana a little bit nervous, while proponents look at conditions like cancer and its related cachexia and nausea as places where marijuana is very effective for many people. And certainly you'll see multiple sclerosis also appears in the verbiage. But this is legalese, a lot of it. And this is an interesting place where legal definitions and the looseness of terms has a very direct impact on our everyday life in transplant clinics, because it allows or prohibits patients from accessing care. So this might be something to either search in your own state, or you can peruse and compare the literature here. But I certainly wanted you to see, and I randomly picked states from across the union. There was no rhyme or reason to that. I did want to show some data over time. This is Dr. Volkow. She's the author of this, and she had a great paper in the New England Journal that I've drawn a lot from 2014. She's the head of NIDA, the National Institute of Drug Abuse, the arm of the NIH that deals with substance use in its many forms. From DEA drug seizures over the years, the THC content in the samples is gradually increasing, which is notable because some of the side effects that we'll talk about can become more relevant. Down here at the bottom, these are divided bars. These are emergency room visits from across the country where drugs are involved. And the blue is the drug that appears down here in combination with another substance. And the red is simply the drug that appears down here alone. And the point that I wanted to draw from this data is that the increase is notable, 62% in combination with other drugs, maybe this slope here, and then 100% when used alone. Some of the other drugs certainly come and go, but it's this slope that makes people think that something might be said about the potency and the medical side effects. and the effect on our healthcare system. We do have some data that's been published in JAMA about some interval data from Colorado about increased healthcare utilization, and there were several domains of health-related symptoms or conditions that were thought to be direct extensions of the legalization in Colorado. Some of them psychiatric, as you peruse, some of them more GI-related or accidental. They're also highlighting that the behaviors that sometimes go along with marijuana use also seem to increase. Motor vehicle accidents are something we won't go into, but one of the challenges for law enforcement that is presented in the literature is the inability to correlate serum levels of THC with any sort of impairment, and it's difficult to sample them. It's difficult to interpret them or use them in a legal fashion. And that's very different than alcohol, which is a volatile molecule and has very predictable clearance from the body. I want to talk about some of the useful indications, some of the risks, and some of the very notable benefits about marijuana. I sort of adapted a table here to sort of give the highlights, kind of parsed into some arbitrary categories here. Marijuana is an effective analgesic for many people and has some anti-inflammatory properties that are highly attractive to our colleagues who treat chronic pain and other inflammatory conditions. And in the states where marijuana laws have been more permissive, there's been fewer opioid-related deaths, which is certainly highly attractive given the state of the opioid epidemic in our country. From a GI perspective, I think we all sort of intuitively know its effects on appetite and reducing nausea for many of our patients, and it's thought to have potentially some use in IBD. Neurologically, multiple sclerosis patients do benefit from this, and those with refractory neuropathy or refractory epilepsy. There are some thoughts, and this is a little bit thin in terms of the evidence, it might be speculative, but in organ transplantation, graft versus host disease, likely secondary to the anti-inflammatory properties and immunomodulatory properties of marijuana, as well as potentially addressing some of the damage to the graft that may occur. The cannabinoid system may have some potential in that regard. This is from Dr. Volkow's paper again, and it's a nice, concise way where she subdivides adverse effects of short-term use and adverse effects of long-term or heavy use. And I just wanted to give you a quick flyover of some of the things that we should be mindful of. Short-term use of marijuana, it impairs short-term memory in many people. And if we think about transplantation and the drug regimens and the care that people have to certain types of diets or certain procedures, this is relevant, along with impaired motor coordination, certainly mentioned driving here, risk of injuries, judgment, what people might choose to do in the short term potentially could be affected. This is something that we unfortunately see with some frequency in psychiatric emergency where I work regularly, that as a formulation of THC increases, as we discussed, paranoia and psychosis, even subclinical, quote unquote, where patients are not diagnosed with schizophrenia, is becoming quite prominent and prevalent, and that's anecdotal, just from my personal experience. I don't mean to say more than I can, but even in my transplant work, I often find patients who are complaining of anxiety, and marijuana could potentially be helping or hurting in those cases. Longer-term use is worth thinking about. We'll talk more about the addiction, so maybe I'll just leave that there for now. But brain development, and that asterisk here refers to certainly exposure in adolescence that is particularly relevant here because of the amount of teen use that we've already talked about. Brain development is thought to be subject to modulation and change and potential damage by heavy use. There are some broader and secondary effects on how people perform in school if they finish school. There are some compelling studies about lower IQ, again, probably dose-related and might be related to people's deficits at baseline in terms of any intellectual disability or developmental delay. There are parts, highly psychological parts of marijuana use that are worth considering in terms of how we experience life satisfaction and our motivation and achievement. Simply more of a pure medical phenomenon, what it does in our lungs if we choose to smoke it or inhale it. And the literature about schizophrenia, actual Axis I psychiatric diagnosis of schizophrenia is compelling, but is not, to my knowledge, causative. It's not something that is thought to cause it, but is highly correlated, unfortunately, with many people we take care of in mental health. You might ask, and should ask, how confident are we in some of these effects that often get thrown around by people who are vehemently opposed to liberalizing marijuana? Some of the domains, you can just look here, we seem to be quite confident as a medical community. Others, less so. And certainly from a lung cancer perspective, we'll talk about that a little bit later, there's not a lot of evidence that marijuana itself contributes to that condition. So this is a paper that's often cited, and it's actually a paper from my institution here in Ann Arbor, where Dr. Inglesby and colleagues looked into nearly 1,500 liver transplant patients who were evaluated at our center and tried to correlate and describe them in a novel way. Those who were using marijuana tended to be younger and male, and they tended to have higher rates of hepatitis C and lower MELD scores. They tended to have more exposure and use of narcotics, benzodiazepines, barbiturates, and stimulants. There was no difference at our center in terms of race, alcohol screen results, or psychiatric background. And, as you'll see here to the right, marijuana was not a factor on the survival post-transplant. And you'll see down here on the x-axis, this is years of follow-up after the transplant evaluation and the cumulative survival. And those curves are essentially the same curve. The factors that intuitively were associated with mortality included age at evaluation, the MELD at evaluation, a patient's status as a hepatitis C patient, and the transplant itself, which is, of course, the reason we do it. This is a powerful concept, and I just didn't want to miss the importance of marijuana as a potential way to manage and deal with our opioid problem. This is a paper from 2014 from JAMA that was a time series analysis of medical marijuana laws and state-level data of all 50 states, of course, some of them not having the same legal statutes as another, but they tried to adjust for this over this 11-year period. And a couple things here, you might notice that the blue line represents states with a law that allows for medical cannabis. And obviously here's the years, and here's the age-adjusted opioid overdose mortality. And you'll see that actually the states that did have access to medical marijuana were higher. But when they adjusted for various state factors, it actually came out that the states with permissive marijuana laws actually had lower annual opioid overdose rates compared to the states without. And this is a paper that is worth looking at and considering. And sort of the second phase to that compelling fact is the fact that this effect of reduction in opioid overdoses actually strengthened and augmented in the years past legalization. So I think this is really compelling and certainly very potent given the issues in our society. This is very thin literature, but I didn't want to gloss over it. There are cases in immunosuppressed patients because of a fungal spore or otherwise a contaminated sample of marijuana that is used by an immunocompromised patient that they've developed invasive pulmonary aspergillosis, which is an incredibly difficult infection to treat from my novice vantage point as not being a pulmonologist or intensivist. But these are few cases, and we shouldn't necessarily make this into more than it is. There's a unique case that was recently published, now I guess 2 years ago now, of a stem cell transplant recipient in his mid-60s who was sort of surreptitiously using marijuana inpatient. And that allowed us to see a particular mechanism of potential interference of marijuana with immunosuppression as he developed diarrhea and body stiffness and tremors. Altered mental status, which many of us are familiar with, suggests a potential toxidrome from a calcineurin inhibitor. Patient was admitted to the ICU, and they found that as he improved, simply by being in the ICU and not using marijuana, that the symptom abated, and they were able to discover that marijuana was the contributing factor in a very compelling way. And what we can learn from this is that cannabinoids do affect the cytochrome 3A enzyme, which also metabolizes tacrolimus. And certainly with the menu of medications that these patients are on, this is not inconsequential. Another CYP3A inhibitor is something to consider. And cannabinoids themselves, as we've talked about, have immunosuppressant properties. So what they would be doing in a patient already immunocompromised is yet to be discovered and understood. The lung cancer risk is low, according to studies like this. This was several thousand cases in a pooled analysis from multiple countries that were compared, and they really did not find a lot of evidence, even at higher doses and exposure rates, for correlation with lung cancer diagnoses. They tried to control for the nature of the habit, the quantity of use, and the duration that patients would use it, and there was not a compelling risk that was found. So I think that's worth considering as well, and there's certainly much more in that paper to consider. This is a compelling slide as well, and maybe we can break this down a little bit. So the marijuana as it intersects with liver disease, which, you know, this audience, we all think about quite a bit. The dark bars are the patients, 270 of them, who are hepatitis C positive, who were undergoing biopsy. They sorted them into daily users and non and occasional users, sort of arbitrarily. And then you'll see that they sort of sorted them in different ways. This over here is alcohol less than 30 grams a day, which is hard to know what that is, but that's a bottle of beer, standard drink, 5 to 6 ounces of wine, 1 to 2 ounces of liquor is about 12 to 14 grams of ethanol. So that gives you an idea of, that's not an insignificant amount of alcohol. This is certainly quite a bit. And then they sorted them in interesting ways. So then they did the age at the biopsy, younger folks over here, older folks over here. And then across the y-axis here is the fibrosis stage, and above F3 denoting higher levels of fibrosis. And sort of across age groups and across alcohol consumption groups, marijuana was contributing to fibrosis. And the strong recommendation of the authors was that hepatitis C patients, whether or not they drink, should not use marijuana. This over here is just a more simplified form where they didn't break them out into as many categories, but I wanted to include that as well. The breakdown of how many people used was not insignificant as well, and I included that here. What happens to our patients who also have HIV? This is an interesting study where they had 690 individuals who were co-infected with HIV and hepatitis C, and they followed them for 32 months. So not an insignificant amount of time, but certainly it's not a decade. what you see here is the APRI score, which is a predictive measure. I had to learn this, of course, not something I think about all the time, but the AST to platelet ratio index. And they log transformed it. And then across the bottom is the number of marijuana joints smoked per week. And these bands, I think, are just simply because they're multiples of 7. I was wondering myself why it looked like this, but I think it's just, 14, 21, 28, 35, just for simplicity. But when they did the best fit line to try and correlate if smoking, increased a rate for cirrhosis, it didn't. And so in this particular case, maybe it's not so clear that there is something going on when it comes to scarring of the liver and marijuana. So this is really where things become interesting when our patients with alcoholic liver disease and marijuana. So there is not a lot of data, but I thought a particular study, even at a sort of basic molecular level and genetic level, was compelling enough just to mention in brief. So when they take mice and then they remove the gene that codes for this receptor, and then they challenge them with alcohol, liver damage gets worse. So the interesting question is, there something about the CB2 receptor system that is protective for our patients who drink and have had some end organ damage associated with that? And on the flip side, as you might expect, when CB1 is knocked out and then they're challenged, there is decreased liver damage. And the obvious question is the CB1 system playing some sort of exacerbating role? To my knowledge, and this is not my specialty, but there's not a lot of data to support this, but I certainly wanted to share it with you in its relevance because clinically this overlaps, as we all know, in a significant way. Cyclic vomiting syndrome appeared on that Colorado slide, if you'll recall, and this is a heterogeneous group of disorders and with uncertain pathophysiology. And we see in some patients that when chronic users stop smoking marijuana, they improve, and that is sort of called cannabis hyperemesis syndrome. That also has along with it some idiosyncratic repetitive bathing rituals that are sort of strange and appear in the literature that you can read about. You might see that in some of the patients. And I mention this and sort of star this. Many patients use marijuana to treat vomiting. So if we're not considering that marijuana itself could be causing it, we might be missing something. We're getting a little close on time, so I wanted to move along. I'll let you peruse some of these on your own. There are various neuropsychiatric effects. Many of them we've already talked about. I would highlight that it's controversial whether these deficits are permanent or they reverse when people stop. And of course, if heavy use is more likely to precipitate them. This is also something we can't gloss over. 9% of people who experiment and use marijuana will become addicted. This increases when we start earlier in life to about 1 in 6 would be our probability of developing problems. And of course, defining those problems would be using the Diagnostic and Statistical Manual, which is adequate in some ways and is woefully deficient in others, but it is what it is. There is a withdrawal with cannabis. This is really important. It is non-specific and it is protracted because of how much THC deposits in our fat cells, but it does occur, and it can be clinically relevant when we take care of our patients. And when people experience these symptoms, they may be more prone to relapse. Marijuana as a gateway drug is a cliche, but it's not worth throwing away completely. There is some signal that early and regular use may predispose to other drug use. As relevant to transplantation, getting near the end here, this is a composite and fictional example, but one that sort of I wanted to definitively outline the complexity here. 52-year-old gentleman with decompensated alcohol-related cirrhosis with 9 months of alcohol sobriety, which is the longest of his life. He comes in for transplant evaluation. He had a chronic narcotic regimen that was recently tapered by his primary care physician, but now he has a medical marijuana card. He's smoking daily and reports adequate analgesia from his marijuana use. just kind of and I don't think that's foreign or surprising to any of us who take care of these patients. The complexity across substances and related to medical efficacy but addiction risk can't be overstated. Mental health, we spend a lot of time with patients. Are they ready for transplant? Do they have enough social support? Do they have psychiatric pathology? Are they mentally stable? Do they have substance use disorders? This is what our colleagues in mental health do in transplantation. And it's a multidisciplinary effort. We need to find contraindications where transplant is not appropriate. And for people who are symptomatic or at risk, how can we intervene so that they can have access to transplantation as well? This consists of serial clinical evaluations, getting collateral information, doing questionnaires and psychometric instruments, toxicology, reviewing charts, coordinating with providers. As you know from your social work and psychology colleagues, this is a massive undertaking for many patients. I'll leave this here about what a substance use disorder is. It's simply a compulsive drive to take a drug despite serious adverse consequences. There are other features about it, but that's a good way to summarize it. We easily slip into stigmatizing it by calling it a moral failing or choice, and there are lots of changes that happen that may be permanent and lots of potential etiologies about who we are genetically and how we grew up and what we're exposed to. Dr. Orloff, who I think was supposed to be the original speaker, this is an algorithm that they use, and we don't have time to go through it, but I would really encourage you. It's an interesting, I don't agree with all of it, but it's an interesting way to sort people through when it comes to marijuana and transplantation. Some highlights here. This was a survey of 100 UNOS accredited programs, and 49 responded. 14% of the programs will transplant active marijuana users, and 28% more will list them if the marijuana is stopped. And it's interesting to point out that more centers will exclude recreational marijuana than will exclude patients who are on methadone. Survival on the wait list is not affected by marijuana use, according to this recent study just published. And here's the last few slides so I can make sure I end right at the 3/4 hour. These are rhetorical questions that I referenced earlier, and I just want them to all sort of settle in your mind. That sounded very psychiatric saying it that way, but I want to leave you with some things that I grapple with. I don't know the answers to these, but I've spent some time thinking about this, and I tried to present these to you for consideration as a field. I wanted to couch them in the 4 principles we all know of medical ethics. We know these. Autonomy means that people can act with intention, that they understand what they're doing and they're not being controlled or manipulated. Beneficence, of course, is promoting patient welfare and removing harm. Non-maleficence, the cliche, is to do no harm. That's either by acts of omission or commission. And justice is that people are equal and resources should be allocated accordingly. How should a transplant team protect a patient's choice to use marijuana? Are there primary or secondary effects of marijuana that impact a patient's autonomy? Should a patient's addiction history and or risk of addiction limit their choice to use marijuana as a liver transplant candidate or recipient? In transplant, how do we balance the benefits of marijuana that we've discussed with its harms? Is it a transplant team's job to decide if marijuana is in a particular patient's best interest? Does the prohibition and withdrawal of marijuana from a benefiting patient violate this principle of beneficence? Are we imposing harm by allowing marijuana in transplant without robust evidence for its use? Should we be preferentially using approved alternative pharmaceuticals before marijuana? How will we know if marijuana is causing harm in our transplant patients? Should marijuana use impact a patient's access to transplant? And what about our alcoholic liver disease patients? Allocating livers, is it ethical to prioritize an abstaining patient over one who uses marijuana when other variables are similar? Should the legality of marijuana affect the allocation of a liver? And I really appreciate the opportunity to talk to all of you.
Thank you, Dr. Winder, for providing such a comprehensive presentation on this topic. We appreciate you sharing your extensive knowledge, research, and experience. So you mentioned that this might provoke some questions, and we do have a few questions here. The first one is, what do you think are the biggest challenges facing transplant teams when dealing with the issue of marijuana?
I think, Andrew, I think the biggest thing is the lack of standardization. It's really hard to standardly measure what patients are using and how it affects them. It's hard to standardize across transplant. Well, even before that, it's hard to standardize it across transplant teams. When we're in eval meeting, it's hard to standardize it. It's certainly hard to standardize it between centers, and it's nearly impossible to standardize it when the legal standardization is in such disarray. We just don't have the data yet. And the last thing I'd say is there are such strong opinions about this. People will react to it as a moral issue, as a cultural artifact of a bygone era that we need to get rid of, or that it's a panacea, that it cures everything, that there's nothing wrong with it. And all of these are really, really complicating factors.
Thank you. We have another question from Amy Muth, and she's asking, how is your program handling medicinal versus recreational marijuana use, and what do you like and not like about the Orloff's algorithm?
Thank you, Amy. If I apologize for the whiplash here. I'll come back to that slide. So our program, our liver program here at Michigan, does not allow medicinal or recreational use for transplant candidates. We tend to fall in that middle ground, if you remember that study, where we will transplant patients if they stop and have a negative screen before their transplant. Some of that is just sort of the culture of the team and the precedent that's been set and sort of how we view the literature as a body. Some of that is insurance-based. We have some insurance payers who will not pay for a transplant unless patients stop, and that invokes the principle of justice. If we tell one patient to stop, what do we do with the other patients? The thing that I am a little bit wary of, Amy, on the algorithm is this part over here. We use a lot of toxicology, and I don't particularly agree that just because we have made a designation of something that is medical or recreational, that we shouldn't monitor it. There are lots of legal and pharmaceutical substances that are just fine for a lot of people, but that can become problems over time. So I think that we should always is a strong word, we should be frequently drug testing patients, and that we should be asking them routinely, like we do about their diet and their exercise and their medical adherence in general, about their marijuana use. So I just thought that that part of it seemed a little bit ideological rather than practical and therapeutic.
Thank you. We have another question that's just come in. What is your program's policy on marijuana use for liver candidates and recipients?
So I sort of just chatted through that. The liver candidates cannot smoke, cannot use marijuana in any form, edible or otherwise. But we take, I guess I could say it this way, we try to understand the broader picture of who the patient is and how marijuana found its way into their life. Is this something that is truly medical and it is being used appropriately, or is it an emblem of something deeper in terms of a more compulsive or deep-seated habit? and that can inform our understanding of the patient in general. That's not anything about marijuana itself. We may look at postoperative opioid dosing in a new light if by what we understood by exploring their marijuana. So we really try to ask a lot of probing questions and occupy a very neutral and non-judgmental stance. We try and normalize without condoning. We try and remove our personal bias. But right now at Michigan, liver transplants don't go forward without negative screens. In terms of recipients, this is a little bit more hodgepodge. I tend to drug test a lot of my patients, and I work a lot so that doesn't disrupt my rapport. But I really want to know, just like an endocrinologist would want to know, is a patient taking their insulin, and how many simple carbohydrates are they consuming? I really, really want to know if my mental health patients are using marijuana.
It sounds like you're definitely expert in communicating with patients on this, but do you have any advice for how other transplant professionals should talk to patients about their marijuana use?
I appreciate you calling me an expert. I have an attack of the imposter syndrome every single time that term is used, but I'm a student of that. I hope I am. I really think that marijuana is a pitfall in the same way that alcohol is. And many of us may have children or relatives who have been affected by mental health challenges or addiction in any form. We may have strong political beliefs. We really are human beings, ourselves as clinicians, and we come to the table evaluating marijuana using patients with all of our own impressions and bias. And I really, really try, being brought up in a Salt Lake City household, which was a very clean household, as you might suppose, to scrub myself of my biases, really try to get down to what the data say, what the clinical judgment should be, and to develop a working and therapeutic reliance with this patient. I just don't think you can go wrong if those are the starting principles.
Thank you. We have another question that just came in from Sarah, and her question is there any data in regards to medical adherence, either pre- or post-transplant, in patients who use marijuana regularly?
Yeah, Sarah, that's that's one of the holy grails of this whole thing. I am unaware of any data, and I'm young faculty here. I don't want to get out over my skis. I am unaware of any data that directly links marijuana smoking or edible formulations to non-adherence. Now, Andrea DiMartini and other senior transplant psychiatrists have done extensive, Mary Amanda Du, they have published a lot about the factors that contribute to non-adherence, and many of those are psychiatric. So I don't think it would be too far of an extrapolation to say that if some of those neuropsychiatric effects are happening in a particular patient, that could be the apathy, that might be short-term memory, that could be a predisposition to a depressive disorder or anxiety. And we know many of those things are factors in post-transplant adherence. If marijuana finds itself contributing or worsening those, I don't think it would be out in the weeds to make a suggestion to a patient or encourage them to rethink their marijuana use, even if it's therapeutic. It's risk-benefit, I think, the whole way down.
Thank you for that answer. And just one final, question we have is, do you have any final thoughts on what transplant teams can do to prepare for the increasing amounts of marijuana use that they may see with their patients in the future?
I do. So transplant teams, I think, are interesting animals. I'm the type of psychiatrist that gets called in the hospital on the floors, when there's somebody on the surgical service or somebody admitted to cardiology and there's a problem. The patient's turning down treatment, or there's, not getting along, there's not the patient and team, not seeing eye to eye. And a lot of what we do, that consult liaison, that liaison piece of my subspecialty, has a lot to do with evaluating the treatment team as well as the patient. And transplant teams, just from my curious eye, are really, really interesting entities because how multidisciplinary they are and how much is at stake when we decide clinical decisions of this kind. So I think that the nature, and Michael Volk, who's now at Loma Linda but was previously here as a hepatologist, wrote about this, some of the decision-making properties and processes of liver transplant evals, and that if you can find that paper, it's fantastic. But I think that the team dynamics, not just around marijuana, but also around substance abuse in general, are really, really important. Now, I don't know, for our surgical colleagues or our, hepatology colleagues, do they wake up in the morning and think, what's my alliance like with, post-transplant nursing? Or, I wonder, how financial coordination views me as an individual. But I think the more nuanced we get and the more we have to deal with the very human parts of organ transplantation as a therapeutic community, as a profession, we have to look at how we relate individually. And I think that teams need to be prepared to disagree. They have to have a place where people can really debate these issues without fear of retribution or that they would, they're going to be scolded. And those team dynamics, I think, are going to be key in, the next steps of having to deal with difficult issues like marijuana.
Thank you. That's great advice. I think we're done with questions. I'm going to turn it back over to Deanna, who will close out the talk.
Thank you, Andrea. It looks like we do have some additional time, so just as a reminder to everyone listening, if you do have any additional questions, please feel free to submit them using the chat feature located in the bottom left-hand corner of the screen. For those of you who haven't done so already, we do have this poll available, and we ask that those of you who are listening in a group, please complete this poll and let us know how many people in your group are listening. I'll allow for some extra time for any additional questions and see if anything rolls in.
I don't see any questions, but I do see lots of compliments for Dr. Winder. So congratulations on a great talk, Dr. Winder. We really do appreciate you sharing all of this knowledge with us today.
Hey, thank you for having me. It's a true honor. I really, really appreciate it.
Yes, thank you, Dr. Winder and Andrea, for both of your time and for an outstanding presentation today. To all of our participants, we'd like to thank you for your time and want to wish you a wonderful rest of your week.